Okay, our third and last speaker in this session, Dr. Alpesh Patel. Dr. Patel is a senior lecturer at Flinders University and is working as an intensive care consultant at Flinders Medical Centre, has been for the past 10 years. His area of interest includes renal replacement therapy and therapeutic plasma exchange. He chairs the FMC MET committee. He is actively involved in developing and monitoring local policies for renal replacement therapy, regional citrate anticoagulation, and therapeutic plasma exchange. Welcome.
Thank you, Tom. Thank you, audience. I'm aware that I'm between you and your lunch. I'll be quick. So what I'm going to discuss about is therapeutic plasma exchange. I will briefly go through the definition, indications, two modalities of therapeutic plasma exchange, evidence behind them, and then share our experience at Flinders Medical Centre. So Hippocrates worked this out centuries ago. What we are doing with TPE is medicine is the art of addition and subtraction, the subtraction of all that is excessive and addition of all that is missing. And who might be the best at doing this, that, and best? A doctor. First, it started with bloodletting, and then we have made it more sophisticated now. So apheresis is a Greek word which basically means you take the blood out of the patient, pass it through and remove a particular component and return the blood back to the patient. Plasmapheresis is removal of plasma, and what we do is therapeutic plasma exchange. That is, after removing the plasma, we replace it with a replacement fluid, which could be a donor plasma, FFP, or albumin or saline. And this can be performed with centrifugal or membrane separation technique. Now, just a brief history. First time the terminology plasmapheresis was used in 1914 by Abel and group, and they basically described plasma removal with return of corpuscles in a dog, and that's how the terminology started. In 1944, first paper was published about centrifugal plasmapheresis in human, and then in 1976, Japanese team reported their first case of membrane plasmapheresis. Across the world now, the therapy is been divided. In Japan and in Asian countries, membrane is more often used, while in Europe and it is mixed, and in US it is mainly centrifugal. In Australia also we use centrifugal more than membrane. So what we are trying to achieve is, we all know in intensive care unit we do CRRT, and we aim to remove small molecules, or sometimes in sepsis we aim to remove middle molecules, or in high cutoff we go for higher larger molecule to remove. But in therapeutic plasma exchange we are aiming to remove albumin and various targeted molecules, immunoglobulins, which are causing a particular disease. So the Apheresis Society, American Society of Apheresis, releases the guidelines for indications of plasmapheresis, and here I have listed category 1 indications, so where it is preferred or treatment of choice for therapeutic plasma exchange. I have highlighted fulminant hepatic failure because before 2016 that was a category 3 indication, and this paper influenced that indication quite a bit. So this was a study which was a randomized trial which was done in UK by Julia Vanden and group, and what they did was they performed high volume plasma exchange. So that means 15% of the ideal body weight was exchanged each day, and they did that for 3 days. So around 8 to 10 liters, which is very high, of plasma was exchanged with FFP on day 1, day 2, and day 3 in acute liver patient with grade 2 to 3 encephalopathy. And what they have shown in their result is their primary endpoint was cumulative proportion survival, and that was higher significantly higher in the high volume plasmapheresis group as compared to standard medical therapy. Now the point to note is all the centers which were involved in this trial were high volume liver transplant centers. So they were good at their standard medical therapy to start with. And so the trial cannot be generalized in other hospitals, but had a significant result. Then they, in their secondary outcomes, they looked at the survival in those who were listed for transplant, and they noticed that those who were listed for transplant but who didn't receive liver transplant had a better survival with high volume plasma exchange as compared to those who did not receive high volume plasma exchange and were not transplanted. And the similar results were seen in those who had contraindication for transplant. In that also survival was better with high volume plasma exchange. So trial which needs further evaluation in other centers with low volume of liver failure patients before we can jump on that. In this same trial, they did proof of concept analysis by measuring the inflammatory markers before and after the first cycle of plasma exchange. And what they noticed was that there was reduction in the inflammatory markers, pro-inflammatory markers, and the reduction in the DAMPs. So they hypothesized that removing these markers may be the reason why high volume plasma exchange helped. So how is the target molecule removed? So to remove the target molecule, it will depend on how much of that is in the intravascular space. So that would be the first component as compared to the extravascular space. So like IgM, IgD, and fibrinogen have large intravascular fraction. 75 to 80% is in the intravascular space. So if there is a disease for which we are doing plasma exchange is mediated by IgM antibodies, then it is more likely to be cleared and the response would be faster with the plasma exchange as compared to IgG or complement, because only 45 to 60% is in the intravascular space. Rate of production, if the target molecule is produced very fast, then you will need to do more frequency of plasmapheresis and more amount of volume to be exchanged if you want to achieve the result. Same thing, how much volume to exchange, 1 time or 1.5 times the plasma volume, which we estimate by this formula. And the frequency, whether we do it daily or alternate day. This graph basically shows that why mostly we do it every 48 hours, because once we do, the IgG level comes down on first plasmapheresis from 80 to 20%, but then it re-equilibrates with the extravascular space and new IgG, and again the levels go up in 48 hours, and that's when it is most effective. If we try to achieve it daily, then we may not get an added advantage. Similarly, this shows that the IgM has a high intravascular space, so IgM is cleared more faster as compared to IgG. And if you are doing 1 time or 1.5 time, it will also affect how much is cleared. So now coming to the 2 modes of therapy, centrifugal and membrane. So centrifugal one is basically based on the specific gravity of the component which we want to remove. So blood is passed through the centrifuge, which separates different substances depending on their specific gravity. And then the plasma is removed, and rest of the component of the blood is then mixed with a replacement solution and given back to the patient. So this is there before the membrane plasma exchange, and this has been now advanced, and now we do both selective therapeutic exchange with that, in which we remove a particular molecule and then replace the rest back to the patient. The advantage with centrifugal is that you need very low blood flow, while the the other modality is membrane therapeutic plasma exchange. Now, in this, you usually need a peripheral access because your blood flow is in the rate of at least more than 100 ml per minute, while with the centrifugal, you can do it with 10 to 50 ml per minute as well. So you can use a peripheral line. And in this, the blood is passed through a membrane, which depending on the molecular, depending on the size of the particle, the plasma is exchanged and the rest of the cell-rich blood is returned back to the patient, again mixed with a replacement fluid, which could be FFP or 4% albumin. Now, for this, we need a membrane, which is different from, so this one, this shows, this is the standard CRRT membrane which we use. Compared to that, the membrane which is used for therapeutic plasma exchange have a higher sieving coefficient for, so the albumin, they have a coefficient of 1 for these membranes. So they have a bigger pore size and surface area. What do we need? The advantage of membrane plasma exchange as compared to centrifuge is that it can be done on the CRRT machines which we already have in intensive care unit. They just need a module in it, and most of the new machines have the option of therapeutic plasma exchange. So we need training around it. We need a central access. That's a bit of an issue, but most of the intensive care patients have, they are on CRRT, or it is not that much of an issue for a patient who is in intensive care unit. But for a patient who is in the ward, it is an issue. We need a higher blood flow rate, anticoagulation. Some sort of anticoagulation is needed with membrane, while with centrifugal, you can get away without any anticoagulation most of the time. So you either need heparin or you need citrate. You will have to decide on replacement fluid. So most of the therapeutic plasma exchange can be done with 4% albumin replacement. You need FFP only in patients with fulminant hepatic failure or patients with TTP and atypical HUS, in which we want to substitute some thing back to the patient, either coagulation parameter or ADAM TS levels. So FFP is only used if a patient is going for a procedure after the in rest of the indication, after the TPE. Or if you are worried, then you can use a mix. Use albumin for most of the plasma volume you have replaced, but only the last 500 ml you can give as an FFP to replace the products. Fibrinogen, because it has a large intravascular volume and it has a longer half-life, is a good marker to see before plasma exchange, if somebody is getting frequent plasma exchange, to see whether they need any blood products or not. And fibrinogen level can be easily measured in all hospitals. We need to monitor, if we are using citrate, then we need to monitor the calcium level as an anticoagulant. So just to summarize, between the two procedures, the advantage of centrifugal is it can be done at a low blood flow rate of 10 to 150 ml per minute, while the membrane requires higher blood flow rate. Membrane requires higher anticoagulation. The percentage plasma extraction, that is the percentage of plasma which is extracted each time it is passing through a centrifuge or a membrane, is better with centrifugal technique. So around 80% of the plasma is extracted once it passes through the centrifuge, while only 30% is extracted here. So to compensate for this, you have to use a higher blood flow rate, and it will take a longer time to do a therapeutic plasma exchange on a membrane. So very hard to find any randomized trial comparing head-to-head centrifugal and membrane plasma exchange. This is the only trial I could find in transfusion, which was by a Croatian group who were, so this is their membrane data and this is centrifugal data. What they did was, it was a randomized cross over study. So they did the therapeutic plasma exchange with membrane first, and then they randomized the next therapy to centrifuge or vice versa. And by doing that, what they found was the setup time was higher in the membrane group, the priming time was higher, and the procedure time was longer in the membrane group. though they were used to using membrane, and the new therapy introduced in their hospital was a centrifuge machine. So it does take longer to do a TPE with membrane as compared to the centrifuge, or it took longer in their trial. But both achieved the same removal of plasma, and it was safe. There were not many complications with either of them. So they both are effective in removing or achieving the therapy, but the centrifugal takes shorter time as compared to membrane. Similar, recently a German group published a retrospective analysis and showed the same thing, that the membrane TPE takes longer as compared to the centrifugal TPE. Complication-wise, the complications are similar to CRRT, what we do in intensive care unit. Most of the complications are related to the anticoagulation, either bleeding from heparin or coagulation depletion, factor depletion, or citrate-related hypocalcemia, hypomagnesemia. Now, briefly, I will show our experience at Flinders Medical Centre. So we started performing membrane-based therapeutic plasma exchange in 2014, July, and soon after this, in a month's time, the hospital centrifugal service from hematology closed for some political or economical reason. So we became the default center for plasma exchange in our hospital. So as you can see, last year we performed every second day. We had one patient almost every second or third day. So we performed total 415 plasma exchange since then on membrane. Number of patients were 77. Median age was 58, and exchanged around 4 to 4. So this is 1 to 1.5 times the plasma volume, compared to the trial which I showed, high volume plasma exchange by Julia Vanden group was around 8 liters. And our indications were, most of them were category 1 indications for therapeutic plasma exchange. Many of them were ward patients because we became the default service provider. And liver failure and liver transplant rejection was the predominant group because we are a liver transplant unit. What we saw was citrate was the most common anticoagulant we used, but we did use heparin in some, and a mix of citrate and heparin. These were the patients with hypertriglyceridemia, which we had problems with clotting, and there is some indication for a heparin infusion in hypertriglyceridemia as such. And most common problem, technical problem we had was high TMP, or clotting of the circuit, happened in 18% of the patients. And the number of circuit per treatment were, in 77%, only one circuit was required. And we were able to achieve adequate post-filter calcium with citrate protocol. So half of 1 or 1.5 times the plasma volume. Most commonly we used albumin. Second was albumin plus FFP. FFP was used in 33% though, because in the beginning we were not very confident, and we used more FFP. And blood speed was around 250 ml, so very high blood speed. Now, for the looking at why we required more circuit on regression analysis, only thing which we found was significant was the replacement volume. If we had a higher replacement volume, then we needed more circuit. So it may be more of a circuit clogging than the clotting and that was responsible for it. And also we noticed that in spite of the protocol and giving significant calcium replacement, we were able to, we were still seeing their post-treatment calcium, serum calcium level was lower as compared to their pre-treatment calcium level. So they do need close monitoring. So in conclusion, in our study, the membrane-based TPE is feasible in ICU with existing resources, and citrate as an anticoagulant with membrane TPE is safe. But there are issues, vascular access issues, if they are ward patients. So it can't be a hospital-based therapy run by ICU. We need both the therapies in the hospital, tertiary center. because the cost implication for ICU, by becoming a default unit, we are bearing the cost of all the patients who are requiring therapy. So our nursing resources are being utilized for that. And anticoagulation management do need close scrutiny and a dedicated nurse to look after the patient while they are getting the therapy on top of their bedside nurse if it's an inpatient. And of course, more ICU studies are needed, and the funding issues. Medicare doesn't authorize intensivists to have the number for TPE. It's only for hematologist or nephrologist. So that is important in long run. Thank you.
Thank you for that talk. Were there any questions on the? Robin?
Dr. Patel, I was just wondering if the cost of the TPE is going to be taken on by the ICU, is there any great difference between the cost of resources for membrane versus the centrifugal?
It's a good question, and which I am also worried about, that probably in our setup in Australia, we may have both therapy equivalent, or maybe centrifugal may come out to be a bit cheaper if we look at it. Compared to IVIG, the centrifugal TPE has been shown by New Zealand group and America as a cheaper therapy for the treatments of disease where both are used. But between centrifugal and membrane, there is no comparison I could find. We are trying to analyze our therapy. It's a bit difficult, and maybe we will have an answer. Thank you.
Thank you.
Thank you. Well, please join me in thanking Dr. Patel.
Thank you.
And that ends this session. Have a good lunch.